Hello everyone, and welcome to my channel. If you're a medical student, an intern, a practicing physician, a nursing student, or a practicing nurse, or you are being managed for diabetes mellitus, or you know a relation that's been managed for DM, then DKA, Diabetic Ketoacidosis, is a subject you should know about. So, welcome and learn about Diabetic Ketoacidosis, DKA, in this video. What is DKA? We'll be considering this in this video. What the pathophysiology of diabetic ketoacidosis, the clinical features, or you could say the manifestations of DKA, laboratory abnormalities and diagnosis, and then the management, the treatment of DKA. Now, diabetic ketoacidosis is an acute disorder related to severe hyperglycemia. DKA is a serious complication of diabetes mellitus that occurs when your body produces high levels of blood acids called ketones. What is the pathophysiology? DKA results from relative or absolute insulin deficiency combined with counter-regulatory hormone excess. And these counter-regulatory hormones are the glucagon, catecholamines, cortisol, and the growth hormone. The decreased ratio of insulin to glucagon promotes gluconeogenesis, glycogenolysis, and ketone body formation in the liver, as well as increases in substrate delivery from fat and muscle. And these substrates are the free fatty acids, the amino acids. It increases its delivery to the liver. The increased levels of glucagon and catecholamines in the face of low insulin promotes glycogenolysis. Ketosis results from a marked increase in free fatty acid released from the adipocytes with a resulting shift towards ketone body synthesis in the liver. So with the excess counter-regulatory hormones, the glucagon, the catecholamines, and then the decreased insulin level, you have the body producing more fatty acid, more ketones, and ketosis results in the body. Elevations in catecholamines and growth hormone increase lipolysis and the release of free fatty acids. Ketone bodies are neutralized by bicarbonates. Now, with the increase in ketone bodies, the bicarbonate store is depleted. Thus, metabolic acidosis results. There's another thing that contributes to metabolic acidosis, and this is the increased lactic acid production seen in patients having DKA. There are precipitating factors: inadequate insulin administration, persistent skipping of insulin doses, or suboptimal insulin dosing can predispose an individual with DM to DKA. Infection has also been identified as predisposing factors. Infections of any sort, pneumonia, urinary tract infection as a UTI, gastroenteritis, sepsis, infections from any foci can predispose a person living with diabetes to DKA. Infarction, cerebral infarction, coronary infarction, this is a stroke, the heart attack, mesenteric infarction are also predisposing factor. Drugs, cocaine has been identified as a predisposing factor, and pregnancy also is a predisposing factor to DKA. Now, what are the laboratory abnormalities seen in DKA? DKA is characterized by hyperglycemia, serum glucose greater than 13.9 millimole per liter, ketosis, and metabolic acidosis defined as serum bicarbonate less than 15 millimole per liter with an increased anion gap. So take note, one of the causes of an increased anion gap is what? DKA, diabetic ketoacidosis. And alongside these manifestations, you see a number of secondary derangements in this patient. Now, this is a table that gives you a glance of the parameters and their values seen in DKA as against HHS, which is hyperglycemic hyperosmolar state. The first is the glucose. In DKA, serum glucose is between 13.9 and 33.3, whereas in HHS is much higher, 33.3 to 66. The serum sodium levels as shown is higher for HHS. Potassium for DKA is normal or slightly increased. Also look out for your osmolarity, which should be around 300 to 320 milliosmol per ml, as against HHS, which is 330 to 380. Now, the plasma ketones in DKA is markedly elevated. That is a hallmark of DKA, markedly elevated plasma ketones. There's metabolic acidosis, and the serum bicarbonate level is less than 15. Now, for the arterial pH, for DKA is less than 7.3, between 6.3 to 7.3, and then for HHS, the arterial pH is more than 7.3, and then the anion gap in DKA is increased, as against HHS, which should be normal or slightly increased. Now, the management of DKA. Confirm your diagnosis. From the parameters I've earlier mentioned, you need to confirm your diagnosis of DKA. Now, patients with diabetic ketoacidosis should be admitted. An ICU setting may be necessary for frequent monitoring of the pH or if the patient is unconscious. Assess the patient, measure serum electrolytes, acid-base status, and renal function. Now, fluid replacement is paramount, is key in the management of DKA, is very essential. 2 to 3 liters of 0.9% normal saline over the first 1 to 3 hours. Then half-strength saline should be given once plasma glucose reaches 13.9 millimole per liter. 5% glucose and half-strength saline should be given. Now, we need insulin administration as part of our management. Administer short-acting regular insulin intravenously at a dose of 0.1 units per kg, then 0.1 units per kg per hour by continuous intravenous infusion. Assess the patient and address the predisposing factors. What tilted this patient to DKA? Is it an infection? Is it an infarction? Whatsoever it is must be addressed. Measure capillary glucose every 1 to 2 hours. Measure electrolytes, especially potassium, bicarbonate, the phosphate, and your anion gap every 4 hours for the first 24 hours. Vital signs also should be monitored alongside, and continue this until the patient is stable. Now, our glucose goal is 8.3 to 11.1 millimole per liter, and also the resolution of acidosis. Once this occurs, insulin infusion may be decreased to 0.02 to 0.1 units per kg per hour. Now, as soon as the patient starts eating, a long-acting insulin should be administered. I hope you've gained value from this content. Now, my reference is from the Harrison's Principles of Internal Medicine. Like this video, hit the subscribe button, drop your questions in the comment section below. Do well to watch my other videos as well. Thank you. See you. Bye-bye.